Hi, good morning, everybody. Thank you, Susan, for the nice introduction. So my name is Luc Puis. I'm a Belgian perfusionist who indeed recently, or I am in the process of moving to Iowa. So today I'm going to talk about the European guidelines that we produced for adult cardiac surgery. And before I go to my presentation about that, I would like to give an answer to a question yesterday about the weaning checklist. And this is from a ER doctor in London who says that it irritates me when people believe safety checklists are only for inexperienced staff. I got distracted. I forgot to put on deodorant this morning. I must have gotten myself ready 10,000 times in the past. So just, as an answer to that. Okay, so for this presentation on the guidelines, I have no conflicts of interest other than I was involved in writing them. So I was a part of the writing group as a chair of the perfusion cohort of that. So what am I going to tell today about this in my presentation? I will tell you how and why we did another round of guidelines for cardiopulmonary bypass, why we thought it was important. I will show you, of course, the results of it, an overview and some examples of guidelines. I will also show you the limitations of producing guidelines in the methodology and the problems we have with evidence, and that we have to find consensus to produce guidelines. And then at the end, I will give some takeaway messages to ponder on. So why and how did we produce guidelines? So in October 2017, we had a first meeting in Lisbon with a group of people who thought it was important to start the process of producing guidelines, or at least at that time, we were talking about consensus statements because we knew that there was scarce evidence on everyday practice. And so, who is we? That is the three major associations in Europe on cardiac thoracic surgery. It's EACTS, which is the European Association of Cardiothoracic Surgery; EACTA, which is the European Association of Cardiothoracic Anesthesiology; and then the EBCP, the European Board for Cardiovascular Perfusion. We created a quality and outcomes group in that board. As a subcommittee, and then these people got on board to write guidelines. And as I said, this was a working document, and in the beginning we called it consensus statements. Along the way of producing them, it became guidelines. And so we thought it was important to do a set of European guidelines as well, because everyone's familiar with the EMSEC standards and guidelines, but many of these guidelines are not applicable in Europe, and that is because Europe is a very heterogeneous group of countries. It's not really the United States of Europe, but it's 40 different autonomous countries, and they all have a different economic and judiciary situation, which leads that all the perfusionists have a different background in training and in I'm sorry, I cannot see that. And they all have a different profession. For example, in France and in Finland, it's anesthesiologists that do the cardiopulmonary bypass. In Belgium, it's mostly nurses with the ICU background. In Holland, it's more engineering people. They have not a really medical background. So it's a whole bunch of different people, and so there's a huge variability in practice, even within countries. There's not much common to practice. So in order to reduce that variability, that is the purpose of guidelines. And guidelines can also offer you a guide to install a framework for quality improvement. They have proven to improve safety, improve the care to your patients and the cost efficiency of them, and they will help you to establish protocols in your practice. And then something that the Brazilian society did was that they use guidelines to empower the perfusion as a profession. The Brazilians also have published guidelines in 2019, and they have a very nice editorial going with that, and they really use it to leverage the perfusion as a profession. A very interesting read. So, but guidelines, you use it every day in your practice. Okay, let's take a look at this. Is a Plan, Do, Study, Act diagram, and most people will be familiar with it. And you do this every day in your practice. You plan an intervention, you plan a cabbage or an AVR, or you plan to do a program about patient blood management, or your surgeon asks, what about this minimal invasive ECC? So you start planning and you look at the literature, and guidelines will help you in that it will give you an image of the evidence that is available at this moment. So you use guidelines to plan your intervention, you do the intervention, and hopefully you collect some data to see what you are actually doing. And then when you use that data, you are going to study what you have done, and you're going to use the guidelines to use as a benchmark to your practice. You will say, okay, if I wrap all my patients, will I actually reduce my blood transfusion rate? Or if I go minimal invasive extracorporeal circulation, do all my patients have less inflammation? Do I decrease the ICU time, for example? So you study the guidelines. You study your practice against the guidelines, and then you can act accordingly, adapt your plan, and start all over again. This is what you do every day in your practice. Okay. So what did you do in October 2017? 2 years before we finally published them. So we chose topics. These are the major topics that we chose, and in each major topic we chose subtopics. For example, if you would have the hardware, then you would talk about the maintenance of your machine, or batteries, or if you talk about disposables, we talk about cannula, of course, and coding and stuff like that. We did a big chunk of preparation for CBP, about checklists and everything, and procedures would then be, we would look for evidence on hemofiltration, wrapping, and stuff like that. And so for each subtopic, we would start asking clinical questions using the PICO method. So you have a population, an intervention, a control group, an outcome, and a time frame to do that. And using these PICO questions, we can then start searching the literature. We had researchers to do that, and they gave us the results of those searches, and we had to then grade the evidence. So what we did was we followed the methodology manual from EACTS. They have a manual to produce clinical guidelines or consensus documents. And the nice thing about this manual is that it tells you what you should do if you are going to produce any guidelines. It tells you what to do. The only problem is it doesn't tell you how to do it. So, and perfusionists aren't really trained to produce guidelines. So this is something that should be in the curriculum, or that can, for the moment, only be done by people with a master's degree, because they've been trained for it. So anyway, in our search for evidence, in our search for literature, we decided to only do adult cardiac surgery, because pediatric cardiopulmonary bypass is something completely different. We only used English literature, and within a few exceptions, we only chose to use literature that was from 2000 or younger. But there were a few publications that we deemed too interesting to just leave out of the evidence. So the results were, well, we kept the same topics. I'm not going to go deeper into all the topics because we came up with 115 recommendations in total. It was a bit, it was a lot that we produced, and the reviews were also very hard. But we managed anyway to produce a nice document. So I'm going to give you some examples of results, of guidelines, of recommendations that we did, and just a little reminder. As you know, recommendations are classified in classes of recommendations, and class 1 is something that we advise you to do, so you should do it, or it is recommended, indicated. Class 2 is divided into 2A and 2B, and where 2A is that the weight of the evidence is saying that it should be considered something to do. Class 2B is where the evidence is less well established, and you may consider to do something. Class 3 is the evidence is, or the general agreement is that it's something you shouldn't do. It's not recommended. These are the same classes of recommendation that EACTA uses, only the wording is different. EACTA would say a class 1 is something you should do, and a class 3 is something you shouldn't do, and class 2 is something you could do. And then every recommendation also has a level of evidence. Evidence A is that you have a few randomized clinical trials or meta-analysis, and so you're sure that about your statement. You're pretty sure about your statement. And level C is there is no evidence at all, or there's just a few case reports. And so most of the time, it's the expert opinion that makes us make that statement. So what do we see here? This is a graphical representation of all the recommendations that we gave. So before, in our first submission, before it was reviewed, we had 115 recommendations, and of those, 35% were class 1. Another 35 were class 2A, 16% was 2B, and then 12% was 3. And then we went into review. We had 7 reviewers who did a really great job. It were very long reviews, because I remember we got the first review back and it was a 75-page document, which we had to go through all the questions. Some of it was a bit egocentric reviews. Some people wanted to push their publications in, but overall it was a very good review, because it really made our document more readable, and we're really grateful to the reviewers. So but what you can see is that after reviewing, and we had 3 rounds of review, we only had we lost 2 recommendations, which reviewers didn't deem important enough or insufficient, and the classification of the recommendations changed a bit. Not much, but nevertheless it changed, and this is of course because you always have to have consensus about a recommendation, no matter how much evidence there is, or no matter which recommendations you have, you will always have the opinion of people to make a recommendation. Okay, so it's not that much of a difference, but it's still there. Now, if we look at the levels of evidence, you see that we have very little levels of evidence A, which means there is not a lot of evidence in the practice. What we do in our everyday practice, there's not a lot of evidence to justify it. We have quite a lot of evidence B, which is not bad, and also quite a lot of evidence C. Now, I want to nuance that result, because we have a lot of level 1, class 1, level C recommendations. Like, for example, if you're going to do cardiopulmonary bypass, you have to have oxygen on your bypass. That is like a no-brainer. it's the common sense recommendation, as I call it. But we chose to publish them anyway. You could say those are standards. This is something that you should do. This really it's a standard on cardiopulmonary bypass. But this has a lot of implementation in Europe. If we would call it a standard, only the European Union can say this is a standard for cardiopulmonary bypass. This is something that needs to be. We would come into very judiciary discussions if we would call it a standard. So we chose to leave it as a 1C recommendation. But anyway, we only have less than 10% and even only 5%, 6% left of level of evidence A recommendations at the end of the review. So we might say we have a problem with evidence. And I will come to that. Back to that later. And so the result was, of course, a publication. Finally, after 2 years, our results were published in October 2019, and they were published in 3 journals: one surgical, one perfusion journal, and one anesthesia journal. They're all free to download, so you can take a look at them. In the European Journal of Cardiothoracic Surgery, there's also a publication with supplementary material, which is very interesting for perfusionists, because we not only talk about the applied methods in the appendices, but also about there's a list of monitoring parameters that we advise, a pre-bypass checklist from the European Board of Cardiovascular Perfusion, a preoperative assessment form, and a weaning checklist, which I talked about yesterday. And somehow we thought it was good to make a summary of all class 1 and class 2 recommendations. But in hindsight, I would say that we should have made a summary of all recommendations, in fact, because there's so many, and this might be helpful. This would have been helpful. Anyway, and then I would just like to mention a nice editorial that was published in the beginning of February 2020 about that discusses the guidelines and the pros and cons of it. So all free to download. Okay. Now, how did we set up these guidelines? How can you use them? So I'm going to give you an example about safety features on cardiopulmonary bypass. First of all, there's a little introduction, why we chose to do these guidelines, or why they are important, and the relevancy. And then we give a description of the evidence, which is exactly what it says. We talk about the literature that we found and the literature that was important, and we discuss that evidence that we find. At the end, we give a recommendation. It's clearly stated. It has the classification and the level of evidence, and if there is evidence, it refers to the publications that we got the evidence from. So this is a typical example of a guideline of a recommendation. And now you might say safety on bypass. We have, in every conference, we have at least 2 or 3 people talking about safety, and you only have one recommendation. Well, this is a nice thing about this document, is that we have safety all over the document, in fact. We think it's very important, and somehow it managed itself to creep into all our guidelines, in a lot of recommendations that there's a lot of recommendations talking about safety. So the first chapter of the guidelines is about training, education, and service delivery. And this is all about safety and the aspects, and that you need to be trained, that you need to have a training, a certification, that you can use simulation, that you have to have standard operating procedures and stuff like that. It's very organic how it came to be. We also have, like, for example, in chapter 4, we have about the hardware. We all talk about the safety devices that you should or shouldn't use. And it's very, very striking that for all these safety devices, there's no evidence of why you should use it. but it's a bit like the recommendation to jump out of an airplane that is at 30,000 feet and you don't wear a parachute. I don't think we can make a randomized clinical trial about it, but you can be quite sure that you will not survive it, although there have been some case reports. But these are all no-brainers, of course. Nevertheless, we had a lot of discussion. For example, we called it a vital systems backup to have, not to have to say you have to have a backup for your pumps, you have to have a backup for your batteries. Everything that is prone to be broken should have a backup ready to be used somewhere in your service. And then one of our reviewers said, yes, but in our center we have a battery that is standing in the OR, and I think we should mention that there should be a battery in the OR. So this is the kind of discussions that we sometimes had with the reviewers. Interesting, but sometimes a bit irritating as well. So we keep on going with the safety. Safety is mentioned a lot during the guidelines. I think overall we have 30 times that it's mentioned in the guidelines. So it's about checking in pre-cardiopulmonary bypass checklists. A preoperative assessment of the patient should be done in order to be more safe. And as we discussed yesterday, checklist before weaning. So these are evident examples of recommendations. Some of the recommendations are less evident and are really ready for discussion because there is not so much evidence handy. So, for example, we gave a recommendation, and I was not involved, but I still feel responsible for the publication of this guideline because I was one of the authors, but we didn't. It was such a big document that it was easy to overlook. But one of these recommendations is the use of any biocompatible coding to reduce postoperative complications should be considered. And it was a 2AB recommendation. I think most of the people could agree that there's this idea that you have that it doesn't matter which coding you use, but you have to use a coding, otherwise you're performing bad practice. In the discussion of the evidence, it was about this last line: in a systematic review of 14 randomized clinical trials, the beneficial effect of heparin or phosphorylcholine coding was shown on postoperative neurologic and pulmonary functions. And I was contacted by the author of this particular publication, and this is the publication. It's about attenuating the systemic inflammatory response. And someone said, like, we don't know where this should be a different recommendation. Well, no, not the recommendation, but they thought the citation was erroneous. It was a different citation that we should have used. And so I went to look at the article, and what they did in that article was they taught about the SIRS after bypass, and they gave a summary of interventions, and they tried to give it a level of evidence if that intervention was beneficial or less beneficial for the inflammatory response. And here you can see that biocompatible circuit coding has a level A, and let's see which literature that they used. And these, I'm not going to go over it, but I looked at all of them, and indeed there's a lot of heparin coding articles. There's heparin head-to-head, but there's no mention of phosphorylcholine coding. So that is a bit of a problem, and this is a mistake that we made, and it's a common mistake that is made. It's just it's the assumption. It has a scientific term. It's called it's a form of bias. And what you do is what you, as a matter of fact, do is that you translate findings that you have in one publication that talks about a whole different subject, but it's also about coding, and you transmutate that citation to a different publication, and the name is citation transmutation, and it's a little bit technical, but it's a form of bias. It's and so you might say that, well, this is a weakness of producing guidelines, of course, and it's something we admit. And you might think, okay, we have a problem with evidence, and so is it still useful to produce guidelines? And I would say yes, but we have to think about how we produce evidence. So do we have a problem? This is a slide from before. So if you look at the level of evidence A in our guidelines, you might say that we have a problem. But we're not alone with problems. So this is a very interesting publication by the American Heart Association, and they looked at guidelines produced by them, and they looked at the guidelines over 10 years, and they looked at levels of evidence and classes of recommendation, and they looked if there was more evolution over those 10 years. And the cardiologists have a lot of money. They have masses. They have big cohorts of patients, and they produce a lot of articles about how they think that they should do their practice. And what they found, nevertheless, despite all these articles and despite all the publications and the trials that they do, is that at this moment, the American guidelines on cardiology, and we're talking about almost 3,000 recommendations, there's only 6% that has a class 1 level A. And in Europe, it's about 10% has a class 1 level A. And this is current, and it was the same way 10 years ago. So despite all the new technology, well, maybe because of all the new technology, it's changing so rapidly, and the industry is pushing it so hard that after 10 years, even the cardiologists have not more evidence to justify their practice. So you can see that the darker the color, the more frequently these levels of evidence and classifications were present. So I made the same. I did the same for the European guidelines on perfusion, and because we have so much class 1 level C recommendations, we have a little bit different outcome, but nevertheless, it's more or less the same. If you use your imagination a bit, of course, so we have a problem. We're not alone, and I think the whole medical field has a problem with evidence. So their conclusions were that only a small percentage was supported by evidence from multiple RCTs, although they do a lot. And this pattern does not appear to have meaningful improved from 2008 to 2018. So maybe we should rethink evidence, and I'm going to go over this shortly. So there's a group of people in evidence-based medicine that thinks that we should rethink evidence, and we should use more consensus, which we do anyway. But we should also think about other ways of producing evidence in guidelines. And so there's talk about there's expert opinion, but there's also expert evidence. That's, for example, someone does a certain thing in his or her practice, and they have good results with that, but it's not published. So if they come into a panel, they might say, okay, we're talking about this, but in our practice, we do a certain thing and we have good results. I will try to get the data out of it, and we can use that as a means of producing evidence. It's just something that is totally different from how we do it now. there is a whole movement now that is evaluating how we produce evidence and has a more philosophical way of rethinking evidence. It's not about it's sometimes it looks like, you know, we're going to a shaman or something to get evidence, but that is not the case. It's more rethinking the concept of evidence and causation. And so it's very interesting to read all this, but I have no time to go through over it. And so people are rethinking the notion of evidence. Another way is big data, of course. Now we are all trying to register our procedures in big registries, and maybe that's another way of evaluating evidence. Like this is about pediatric cardiopulmonary bypass. This is an editorial about the stress trial. I think it's about using corticosteroids in pediatric surgery, cardiac surgery, and they just use the STS database, and with the help of the data managers, they managed to add a few fields, and with an existing registry, they did in fact a randomized clinical trial, and which is much cheaper and much easier to do. And a recent publication in Perfusion from the Perfusion Down Under registry looked at a cohort of almost 31,000 patients, and they took out all of the Jehovah's Witness patients and see how the management of the cardiopulmonary bypass was done with regard to acute kidney injury. So I'm almost done. Just a few conclusions and some pondering. First of all, and many people's hairs will rise, but a guideline is just a guideline and should be interpreted with the evidence that is presented with it and with the discussion that is there. It's not because it's a guideline that you all should do it. Okay, you always have to. A guideline is just a part of quality improvement, and then the evidence is not always there, and for some things it might never be, or maybe we should produce it in a different way. And what is very important, because we're talking about human work, even a strict methodologic sound guideline is still the product of a consensus and an opinion-based discussion. If you would have artificial intelligence producing guidelines, I think that there would even be less stronger guidelines. Because the evidence is just not there and it's difficult to interpret it. Thank you very much.